Antiplatelets pharmacology. Before we study the pharmacology, we must have a little bit short concept about the adhesion, activation, aggregation of the platelets. Well, coming to the point, in the blood vessel, there are some inactive platelets floating. Whenever the blood vessel ruptures or it is injured, so what happens? The endothelium layer is removed and subendothelium is again exposed, and there beneath the subendothelium we have the collagen fibers. When the collagen fibers are exposed, you know about that, the von Willebrand factor is supposed to bind to this collagen fiber. And when these floating platelets, when they see that here is a von Willebrand factor available, then these platelets will come and will bind to this factor. Well, now this is the blood vessel and these are the two floating platelets, and I have just zoomed the picture a little bit. This is your first platelet, this one, and here is another platelet. So consider that this procedure is happening inside the blood vessel. Well, so now this platelet, when it reaches the von Willebrand factor, it has two types of receptors on this platelet, known as GPIB or GP1B and GP1A. GP1B will bind to the von Willebrand factor, and this GP1A receptor of this platelet will bind with the collagen, exposed collagen. So now like this platelet will bind with this von Willebrand factor and the collagen. This mechanism is actually known as platelet adhesion. So now when this platelet binds by means of the GP1A and GP1B to this von Willebrand factor and the collagen fiber, this platelet will become activated. And let me tell you about the GP. It stands for glycoprotein. Okay, this is a receptor made of glycoprotein. When this receptor becomes activated, it will release some sort of granules present in the vesicle inside this platelet. In the platelets we have some vesicles, and that there are some kind of granules enclosed in those vesicles. Those granules, when they are released, these are actually called as aggregating factors, known as serotonin, ADP, thromboxane A2, and etc. Some of the factors are also available. Now, what happened? First of all, this platelet adhered, that is called adhesion. Then this platelet became activated. This is called platelet activation. Now, the third step, platelet aggregation, will just be because of these factors. These are given the name the same for this reason, that they are called as platelet aggregating factors, because they will help in the platelet aggregation. So how will these help in platelet aggregation? We know thromboxane A2 and ADP and serotonin and etc. some other factors which are responsible to do the aggregation. So how will they do? Let's come to the first one, thromboxane A2. It is responsible for the platelet aggregation. Means that it will go and it will stimulate other platelet to, and it will then call that platelet to adhere or to aggregate on this activated platelet. So this is called as aggregation. Now, how thromboxane A2 is doing its job? Well, thromboxane A2 is actually not from the granules which are present in the vesicle. Thromboxane A2 is actually formed from the membrane which encloses these granules, or which encloses other aggregating factors. So this membrane actually, it is made up of phospholipid. When this phospholipid membrane is decomposed or somehow broken, it will release arachidonic acid. And this arachidonic acid is then converted to prostaglandin H2 by means of an enzyme known as COX-1, cyclooxygenase type 1. Now this COX-1 converted arachidonic acid into prostaglandin H2, and then this prostaglandin H2 will undergo the process of metabolism. What is produced? Thromboxane A2. Now here is our produced thromboxane A2 from this membrane. This thromboxane A2 is supposed to bind to the receptor present on the next platelet. We have here these two platelets. Now one became activated, these released the aggregating factors, and one of those factors like thromboxane A2 came and bonded to this platelet. So this platelet has got one receptor known as GQ coupled receptor for the thromboxane A2. This thromboxane A2 will bind to this receptor, and this is GQ coupled, and you must have the knowledge of the GQ, GI, GS. Because these are very basic topics. We have discussed this in our very first videos of the pharmacology. Well, I will just give you a little bit short review again, that when this GQ is activated by means of this thromboxane A2, this will in turn activate phospholipase C, which will activate PIP2, and which is then in turn releasing the IP3 and DAG. IP3 is responsible to release the calcium from the endoplasmic reticulum. Now here will be the calcium available. Now the calcium will be released and this calcium will come here. Now what is the job of this calcium? And you know, whenever you hear the calcium and vesicle, so you must click that the calcium is responsible to fuse the vesicle and release whatever is present in the vesicle. You know that in the vesicles we have aggregating factors. And now these aggregating factors are thromboxane A2, ADP5, hydroxytryptamine, etc. So they will be released. And these aggregating factors will then again in turn stimulate some other platelets. Again, they will again release the same things. Well, coming to the next point, DAG. So IP3 released the calcium, which just fused the vesicle with the membrane and released the aggregating factors present in the vesicle. And now what is the function of DAG, diacylglycerol? It is supposed to target this GP2B3A receptor. And this receptor, when it is activated, what is its job? You know, this platelet and this platelet. This is activated one, and this one is going to be activated now. So these two platelets, or you can say two platelets, are actually joined by these types of receptors, GP2B3B3A, GP2B3A. These receptors are actually joining two platelets by means of fibrinogen. So one platelet will combine with another platelet by means of fibrinogen. So like this, it will cause the aggregation. So this is the way how the thromboxane A2 is activated and increasing the aggregation. So thromboxane A2 was releasing the IP3, which was releasing the calcium, and then it was stimulating diacylglycerol, which was in turn stimulating this receptor, and this receptor was actually combining by means of fibrinogen with another receptor present on the activated platelet. Like this, they were increasing the aggregation. And well, when we are studying the pharmacology, so we concentrate some other factors also, which are responsible for aggregation. This is thromboxane A2, and we have another one, that is ADP, and some other factors like phosphodiesterase inhibitors. So coming to the next one, this is the way how thromboxane does the aggregation. Now coming to the ADP, when ADP binds to the receptor, now this ADP receptor is actually coupled with the GI and as well as with the GQ. And you got about the concept of the GQ, how the GQ is doing the aggregation or helping in the aggregation. So this is the way how GQ is doing. And coming towards the GI, and you must know about the GS also, because GI is actually inhibiting the way of GS. You know, in order to understand the ADP GI protein coupled cascade or pathway, we must know about the GS pathway also, because actually this ADP is stopping or binding or inhibiting the path of the GS. So what happens normally is that GS actually targets the adenylyl cyclase. When it activates this adenylyl cyclase, it will convert ADP to cyclic AMP. Now when ATP is converted to cyclic AMP, now these cyclic AMP, this is responsible to activate the protein kinase A. Now what is the job of protein kinases? Protein kinases, they will actually add the inorganic phosphate to some already available enzymes or proteins. Here we have some enzymes and proteins. This protein kinases will actually add this inorganic phosphate to these enzymes or proteins. Then what will happen? These enzymes, when they are phosphorylated, when phosphate is added in them, they will become inactive. This is the general pathway, general way. So now what ADP does, when ADP binds to this receptor, it activates two pathways, GI and GQ. GQ, you got the concept. When it activates GI coupled pathway, when GI protein is stimulated, it will actually inhibit the adenylyl cyclase. So when adenylyl cyclase is inhibited, ATP is not converted to cyclic AMP, and cyclic AMP is not going to be acting on the protein kinases A. You can say protein kinases A, they are not stimulated or not activated. So when they are not activated, their job was to add the phosphate to these proteins, these enzymes. So now what happened? Actually phosphate is not available now because the path is stopped by means of GI. So now this, instead becoming inactive, now this enzyme or this protein will become active, and this activated protein or enzyme, it will then bind to the GP2B3A receptor. It will activate this receptor. And you know, when it is activated, it is supposed to bind with another platelet because it has a receptor for that by means of fibrinogen. So this platelet will bind by means of fibrinogen with this platelet when this receptor is activated. So this is how the GDP, when it binds with the GI coupled receptor, this GI is inhibiting the pathway and activating the GP2B3A receptor and increasing the aggregation. Means one platelet is now going to bind with another platelet. And here we have another enzyme, phosphodiesterase type 3, which is responsible to break this cyclic AMP. And again, when this is broken, what is going to happen? When there is no cyclic AMP, there is no protein kinases activation. When it is not activated, protein kinases, kinases, they actually add phosphate, inorganic phosphate to these proteins. So now when this is not activated, these proteins are not phosphorylated. And you got the concept. When the proteins are not phosphorylated, they will become active. This concept you must keep in mind. When these proteins or these enzymes are phosphorylated, they will become inactive. So now here, this phosphodiesterase is actually inhibiting cyclic AMP, or you can say this is inhibiting protein kinases A. So when protein kinases A is not activated, so then they will not add phosphate to these proteins, and these proteins will become active. And activated proteins or enzymes, they're actually targeting the GP2B3A receptors. And when this receptor is activated, you already got the concept. It is going to bind with this next activated platelet by means of the fibrinogen. Like this, it will increase the aggregation. So this is how aggregation happens by means of the ADP, phosphodiesterase, thromboxane A2. Coming to the pharmacology, we have COX-1 inhibitors named aspirin, ADP inhibitors clopidogrel, GP2B3A inhibitors abaciximab, phosphodiesterase inhibitor cilostazol, and we have some other drugs also. Well, coming to the very first one, that is COX-1 inhibitors or aspirin. Aspirin actually targets the COX-1. Here is, when we give aspirin, it inhibits the COX-1, which is responsible to convert the arachidonic acid into prostaglandin H2 and thromboxane A2. So when we inhibit the COX-1, there will be no formation of thromboxane A2, and when there is no formation of thromboxane A2, no GQ stimulation, no IP3 release, no DAG release, and when there is no IP3, there is no calcium. When there is no calcium, there is no release of the aggregating factors, and when there is no DAG, there is no stimulation of GP2B3A receptor. When there is no release of the aggregating factors and no activation of GP2B3A receptor, so then these aggregating factors will not stimulate other platelets, and then this GP2B3A receptor is not activated, so this will not join by means of fibrinogen to this activated platelet. So like this, we actually stopped the aggregation of this platelet with this platelet. Coming to the next one, ADP inhibitors, that is clopidogrel and etc. When we give ADP inhibitor, so when ADP inhibitor is given, ADP is not going to join or bind to this receptor, and the function of this receptor was to stimulate the GI and GQ proteins. So when we inhibit the GI and GQ, so you got the concept of GQ, it will not release the AP3 and DAG. When we inhibit GI pathway, so it will not inhibit now adenylyl cyclase. Now adenylyl cyclase is free, so ATP will be converted to cyclic AMP, and it will then activate protein kinases A, and this protein kinases A, when they are activated, they will add the inorganic phosphate to this protein or this enzyme. Then this will become inactive. When this is inactive, then what will happen? Then it will not stimulate GP2B3A. So when it is not stimulated, then this receptor has no path to join with this activated platelet. Like this, we stop the aggregation. So this is the function of the ADP, thromboxane A2 ADP inhibitors. We got the function of the aspirin, and here we got the concept of the clopidogrel. And coming towards the next one, GP2B3A inhibitors like abaciximab and some other drugs. When we give the inhibitors of the GP2B3A, so when we inhibit this receptor, what will happen? No fibrinogen, no platelet aggregation. So like this, we can inhibit the aggregation by means of blocking this receptor directly also. And coming to the next one, that is the phosphodiesterase type 3 inhibitors like cilostazole and etc. Coming towards the phosphodiesterase inhibitors, which one? Cilostazole. Now, what is the mechanism of action of phosphodiesterase inhibitors? You know the function of phosphodiesterase inhibitor. It was breaking the cyclic AMP, or you can say in short that it was actually activating these enzymes and proteins. So now when we inhibit the phosphodiesterase enzyme, so now we will have enough quantity of cyclic AMP available. It will activate the protein kinases A, means its activity will be increased. And you know the function of protein kinases A, it is supposed to add the phosphate to these proteins or enzymes. Then these proteins and enzymes will become inactive. And you know when they are inactive, so then GP2B3A, they will be not activated. So like this, when this receptor is not activated, this is not going to bind with the fibrinogen or with this another platelet which is active already. So like this, we are actually stopping the aggregation of one platelet with another platelet by means of phosphodiesterase inhibitor, by means of the ADP, by means of the thromboxane A2 inhibitors, you can say COX-1 inhibitor, that is the aspirin. So these are the medications that are helping us to inhibit the aggregation. So this is a little bit from my side about the antiplatelets pharmacology. If still you have any kind of question regarding the topic, you can drop that in the comment box. We'll come for the answers very soon. Thank you for watching.